So, Dr. Chu, please.
Thank you very much, Dr. Samrat. Hi, I'm Chow. I'm from the Singapore General Hospital, and these are my disclosures for today. Now, we're going to divide, and so there have been a bit of overlap in the talks, but we're going to delve a little bit deeper, and these are the three categories that we're going to talk about. So papillary thyroid microcarcinoma. So this is PTC, that's deemed as low risk, less than 1 centimeter. Differentiated thyroid carcinomas, so these are slightly larger PTCs, or follicular or medullary, and recurrent disease post-surgery. Now, I have to warn everybody there that while we have seen quite a bit of evidence, the evidence for cancer is really not so clear-cut, and we will go through why. Now, first, papillary thyroid microcarcinomas. Now, the treatment of papillary thyroid carcinomas is controversial on its own in surgery, and it's really because they have excellent prognosis, 97% 10-year survival with surgery. I have professors telling me that, if you've got to choose one cancer to have in your lifetime, this is one of them. Now, the vast majority are incidentally discovered because, well, we are scanning more thyroids than ever before. Now, we do know that although we have picked up so much more PTMCs, there is no change or mortality. So are we over-treating these people? And hence, active surveillance for low-risk tumors is a management thing. Now, the first of all, it starts with Ito et al. 2014, and this came from Japan, from the Kuma Hospital, and this is how they define PTMC and what they want to do for active surveillance and what triggers treatment. So the first paper used 3 mm, as you can see. Subsequent treatment started using greater than 50%. Now, they found that PTMC in young patients less than 40 years old may progress faster than in older patients. Now this is definitely quite easy to think about. Young patients have a longer runway. Maybe they should get surgery or more definitive treatment because they have longer to live. Subsequently, the subsequent papers, most of them use volume increase by 50% as size enlargement. And you can see that most of them thinks that it follows predictable kinetics. Once again, for O et al. In 2018, the risk of increased volume in size is the highest in under 45 years old. So if you are going to offer active surveillance, maybe in the older population. Now, the advantages and disadvantages of offering active surveillance is really as follows. So nobody wants extra surgery that they don't need or outcomes. Whereas the disadvantages, as some of the other speakers have said, is a long follow-up time. You need ultrasounds yearly and patient anxiety, as well as cooperation on both the patient and the doctor side. And we may miss aggressive histologies on FNAC. Now, the issues here with active surveillance is when should we act? Kuma Hospital shows us the tumor size 1 and 3 mm. Subsequent authors says increase in 50%. Now, cervical lymph node certainly needs to be evaluated. If there's no abnormal cervical lymph nodes, you are okay for active surveillance. But what we do know, for those of us who practice diagnostic ultrasound, the central lymph nodes are notoriously difficult to assess on ultrasound. And this is what we're missing in a lot of times. So we do know for PTMCs, for those that are operated, while the ultrasound is clear, sometimes we do get 1 or 2 positive central cervical lymph nodes. And of course, cost effectiveness. Is it truly cost effective to follow up patients? So this is one of the example, probably one of the largest studies so far for ultrasound-guided ablation for low-risk PTMCs. Follow up quite not too bad, across about 10 years, size more than 1 centimeter, all pathological defined with no evidence of extra thyroidal extension of metastases, who had medical contraindication or refused surgery. These are good lesions to do with some hydrodissection of the trachea, and we can ablate them. Now, complication rate is quite low, overall 3.06%, major only 0.8%. None of them are life-threatening, certainly no decreased thyroid function, local tumor recurrence, cervical lymph node metastases, nothing, no additional surgery because of pancreatic cancer. So this is quite good result as compared with this other chart, how far we have come. All reports quite good results. The basic question is the follow-up period long enough? Is 5 to 10 years long enough for PTMCs, for such great survival for cancers? And this is something I think that does have not settled. Now, Professor Giovanni has gone through this, and we will then not go through too much of this. So again, is favoring ablation when they can't get surgery, they don't want to get surgery, then we can offer favoring surgery for young patients, who are worried, etc. And of course, technical expertise. We now move on to differentiated thyroid carcinoma. Now, in the CCMA ETA guidelines, we should only consider these preferentially in the context of a multimodality approach in patients with primary thyroid cancer other than low-risk PTMCs. And this paper out of China is probably one of the landmark papers. Safety and efficacy for terminal ablation for solitary T1. Now, T1 for PTC is under 2 centimeters. So T1A is under 1 centimeter, T1B is under 2 centimeter. Both groups have very good survival outcomes, as you can see here. But certainly when you get larger in the T1B group, you're going to run into more complication rate. And this is something that we need to recognize. The thyroid is a very small organ. And once you start to do a 2 centimeter lesion and you want margins, and this is where we start running into problems. Certainly not something that you want to try on your first go. Now, the other thing about follicular neoplasm that I think is understated. So again, a follicular neoplasm is very hard to diagnose on fine needle aspiration. It can be a follicular adenoma, hyperplasia, carcinoma, and Hutton cell neoplasm. It's really because the pathologists need things like capsular, vascular, or extra-thyroid tissue invasion. Core biopsy in this arena still remain controversial. Certainly, my own pathologist has called me up sometimes and say, "Why are you doing a core biopsy?" I say, "I need to RFA the patient. I'm so sorry." Now, small series have supported the use of ablation for follicular carcinomas below 2 centimeters, but this remains controversial. So if you're going to offer ablation for follicular neoplasms, you need to tell your patient. My personal tip is they must look benign on ultrasound, get informed consent, and get a longer follow-up for these patients. Now, recurrent thyroid carcinoma, this has been covered as well, and these are the 2 reasons why. Now, personally, on the MDTs, I get referred patients post-neck dissection and post-radioiodine. Once they have both of them, I'm happy to offer really because there's nothing much going on. Safety and efficacy wise, when we compare radiofrequency as well as ethanol ablation, now both are acceptable modalities with acceptable efficacy as well as complications. But again, we do not have long-term survival data or comparative data in this arena. And this is something we must remember. Although we are offering treatments and we are in a way cherry picking all these tumors out, we really do not have data yet on long-term survival. Now, this is really one of the first cases that we have done. As usual, when we first start out, people refer you cases that nobody wants to do. 47-year-old Chinese female, primary pulmonary hypertension, so cannot undergo GA. And she presents with 2 very angry looking PTCs on the left and right side. And it's really no fun. But because she really has no other option, we decided to go ahead and ablate. In 2014, we ablated each side of them. Both nodules get smaller until 2016, whereby the treated right-sided nodule got bigger with a new nodule. Although the left side was very quiet, I went to re-ablate the nodule in 2016. 2017 still have flow. And this is something, so as Dr. Giovanni has said, well, you can do a contrast-enhanced ultrasound. Sometimes with very high-end linear probes, you can pick up very small vascularity. We go ahead and repeat ablation. Finally, in 2019, after 3 ablations and about 4 years, we have no flow detected. She's still alive, although now she's getting complications from other parts of her primary hypertension. So the lesson here is, I think we can help patients for those people that cannot undergo surgery, but do remember, these are not easy procedures to do. You may need repeated procedures. For the safety and efficacy of ablation of benign and nodules and recurrent thyroid carcinomas, look here. Overall and major complication rates are significantly higher for malignant thyroid nodules. And this is something you need to know when you transit from the benign nodules to treat the malignant nodules. And why? And certainly because post-operations, there's altered anatomy to the neck. Lesions can get very close to the nerves, really along in between the carotid and the jugular. It happens all the time. We need to ablate beyond the size of the tumor to get good clearance. Now, this is not usual. The unusual complications I encounter sometimes, a very persistent cough. Maybe I hit the vagus, maybe I hit the superior laryngeal nerve. And there's one patient whereby it was a bit overly aggressive because she got a couple of nodules. She got laryngeal edema after that. Now, she didn't get a recurrent laryngeal dysfunction. She got a laryngeal edema, which one of my close friends, ENT, diagnosed for me and said we should watch. So this is something that you really also need to find if you want to start to do malignant work. Get an ENT who understands voice. Not all of them do, and certainly those that refer to you for ablations may not treat vocal cord disease. If you want to start doing malignant disease, it's time to make friends because they can really help you out when things go wrong. So finally, what happens when they invade the thyroid cartilage? Professor Beck et al. Classify into acute angle, right acute angle, acute angle, and of course when there's tracheal ablation. And certainly as you start getting the difficulty from the left to the right, you're going to get more complications as well as less successful ablation. So this is one of my own case for obtuse angle. First thing I did was to hydrodissect the tumor away from the trachea. You will be surprised. You think that you can't do it, but quite often you can do it quite well. I also then hydrodissect away from the carotid, and then I start ablating. If you're more adventurous, Professor Beck described stenting the trachea first so that the invaded nodule becomes everted out into the neck, and that's when you can carry on ablation. And then, as you can see here, great result. Although I must warn everyone that there are reports of tracheal necrosis post-ablation in this arena. In conclusion, treatment of PTMC by ablation is controversial. Treatment of PTMC on its own is still controversial. Ablation is certainly effective, but is it oncologically appropriate? And this is something that we need to ask ourselves. 5-year survival outcomes look similar to surgery, but are they too short? And how does this compare versus active surveillance? When we are treating differentiated thyroid carcinoma, remember that we are doing it with palliative intent. For patients that can undergo surgery, we cannot promise cure. Non-surgical candidates, however, we should have no problems offering them. Do note that you're getting higher complication rates when you're doing benign lesions. You may need repeated treatment, so warn everybody. So beware of follicular lesions. The dust is not settled on that. For recurrent disease, what I'd like is when they have gone for RAI and neck dissection and still get nodules, and we'll go and cherry pick them. There's no data on long-term survival. And certainly for me, I have sent patients I have done patients after RAI and thyroid dissection and ablation back to back to neck dissection before. And because the systemic therapy and the TKIs are not really very effective yet, we continue going. And again, not much data is out there, but we do carry on with the patient. That being said, I'd like to make the first announcement of the radiology conference in Singapore, SGCRYS, our both diagnostic and interventional radiology conference in August 2020. I'm part of the organizing committee, and here are the rest of my partners. The theme this year is Augmented Radiology. Now, I'm sure this sentence by one of the fathers of AI gave us all the wrong feelings, and this was actually 5 years ago, and we are still training radiology. So we are not being destroyed, or rather we want technology to augment us. And the theme this year wants to explore that. We have lots of themes. Breast, AI, IR are the main themes all across the others. We invite you to save the date and to follow us on internet as well as Facebook. In addition, our Emergency Radiology Society is having a conference webinar in January 2020, 14 to 15 of January, with lots of interesting topics that will be entertaining, I'm sure, over 2 days. So we also ask you to register now. And with that, thank you very much.